I'm Dr. Peter Apel, attending here at Virginia Tech Carilion, and I'll be talking today on complex regional pain syndrome and really focused on, as a hand surgeon, what do we need to know? So you might ask yourself, why do we care, right? We're hand surgeons. And the reason is that the initial presentation is usually to us, especially for upper extremity CRPS. Certainly it can be a complication of some of our operations. And there's a phrase, to know your enemy from the art of war. And it's important to know about this type of complication so that you can treat it. You can recognize it and then you can treat it. One of the old expressions goes, the eye only sees what the mind knows. And for those reasons, it's important to know what complex regional pain syndrome is. And then lastly, you can cure the right patient. If you can identify somebody who has a surgically curable cause of CRPS, you can cure them. So with that, let's get into the talk. So first we have to understand what it is. So what is complex regional pain syndrome? So this is regional pain combined with autonomic dysfunction, atrophy, and functional impairment affecting musculoskeletal, neural, and vascular structures. So really it's a composite tissue problem where it affects all the tissue types in the extremities. Pain is the sine qua non, the without which not sign and symptom of complex regional pain syndrome. It's not a psychogenic condition. This is not a psychiatric condition. This is not malingering. This is a real physiologic problem. It goes by many synonyms. You can stop the video and look all these up if you want. You can take a look at these. Probably the most common are causalgia. That's the old term for it, meaning burning. Costos it means burning. And then you'll hear reflex sympathetic dystrophy, which is what it went by most of the last century. Causalgia, which was the original name for complex regional pain syndrome, comes from the classic Greek. Kostos, which means fever or heat, because of the burning pain that folks complain of when they have this. And algia is the suffix that means pain. So from Green's, the textbook definition says that the diagnosis of CRPS is based on the patient's history and physical examination and relies on the intuition and experience of the clinician. Additionally, Green's tells us that a dystrophic process should be considered in all patients experiencing pain that's out of proportion to the traumatic or surgical insult and that inappropriately influences function or outcome. Furthermore, it tells us that imaging, serum biomarkers, and laboratory tests cannot be used to make the diagnosis of CRPS. And here's the photograph from Green, and this shows that classic appearance to it. You can see here in the left hand that sort of shiny, semi-flexed hand with edema throughout. That is classic complex regional pain syndrome. Here it is on the volar side. You see those fingers as they're, in the semi-flexed position. You can see the shininess there on the tip of the thumb. There's some rubor in the palm as well here. So this is what it looks like. So you can do adjunctive testing to confirm the diagnosis of CRPS if you have access to a thermography lab. You can clearly see there's increased temperature. Sometimes you can tell that by either putting surface temperature probes on or just feeling with your hand. Laser Doppler fluxometry looks at the cutaneous microcirculation and can tell you about the blood flow to the area. Cold stress testing can be helpful as well. Bone scan will show increased uptake. As you see here, this is a bone scan, and you can see that increased uptake in the wrist as well as in the MP joints and really all throughout the bones of the right upper extremity here. You can see, and that's a classic finding in CRPS as well. Here's a thermography scan. You can see how warm it is on the right compared to the left. On the left, you've got those white areas, on the left, you've got those white areas, which are the areas of increased temperature, and you can see that there in the palm and in the distal wrist, and that's the hyperthermia or the increased temperature associated with CRPS. The yellow there on the right is some of the more cooler temperatures. The white is much, much warmer. So with these together, sometimes I think of this like Justice Potter Stewart, wrote about obscenity in a 1964 U.S. Supreme Court decision where he said, "I shall not further today attempt to define the kinds of material which I understand to be embraced within that shorthand description. And perhaps I never could succeed in intelligibly doing so, but I know it when I see it." And CRPS is kind of like that. It's hard to pin down the definition of it, but we certainly know it when we see it. There's the Budapest criteria for CRPS. I would encourage everybody to take a look at this at some point. But there's four main pillars, one of which is continuing pain, which is disproportionate to any inciting event. You acquire symptoms in all the following four categories: sensory, vasomotor, pseudomotor / edema, and then motor trophic. And then you have to display one sign at the time of evaluation of two or the more of the following: sensory changes, vasomotor changes, pseudomotor changes, or motor and trophic changes. And then lastly, it has to say that there's no other diagnosis that better explains the signs and symptoms of it. So there's lots of criticism of the Budapest criteria for CRPS. I think for me, the main criticism that I have is it's a really high threshold. So you'll see patients who come in who have symptoms of neuropathic pain, who are developing CRPS, who maybe don't have all of these criteria, but who clearly are in the early stages of neurologically mediated pain and will likely blossom into full-blown CRPS. And so, so my way of understanding the Budapest criteria, or what if I took that same reasoning and set the threshold so high to determine, for example, when it's raining. So here's what I'm going to call the Pensacola criteria for raining, right? And this is a reductio ad absurdum argument demonstrating how the Budapest criteria, if you take them to the nth degree and apply them anywhere else in your life, you would realize that such a high threshold is not useful for decision making. So for example, if we were saying, well, how do you know if it's raining? You would say, well, there is continuing rain, disproportionate to what I expected. You know, it must report one symptom from one of the following categories: a wet coat, cold and wet water outside my jacket, sweat and moisture inside my jacket, difficulty traveling due to needing wipers, etc., etc. You could go on and on with this and say, well, let me set this really high criteria to know that it's raining. And in reality, you know if it's raining based on how it smells outside, based on some early signs of maybe some mist, on the windshield, of the clouds, And so the point is that you use a lot of your skills of observation and knowledge of unfolding of natural events to make decisions. If you look outside and there's storm clouds brewing, there's mist that's just starting to form on your windshield as you're driving, you might say, look, I think it's going to rain, and I'm going to plan accordingly. So just like that, if you see somebody in your clinic and they've got pain out of proportion, they've got early trophic changes, they've got neuropathic type pain, maybe they don't meet the Budapest criteria for CRPS, but you had probably better start initiating treatment. So that's the whole point of these two slides. So with that, let's move onward. So we all spend a lot of money, to graduate from medical school. Last I checked, the 4-year cost was over $275,000. And so why don't we go over some medical words related to pain and changes in our nerve sensation. So let's start off with a definition of pain. Like, what is pain? So pain is an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage, described in such terms. So pain, it's important to know, is both the nociceptive input as well as the distress associated with it. And that's why people can have pain, will feel pain differently. People who are who are emotionally fragile feel higher levels of pain. People who are incredibly emotionally stable will feel less pain. And it has nothing to do with the nociceptive input. It has to do with the emotional state associated with it. So let's go over some fancy doctor words. We'll just start with level 1 words here. I hit my thumb with a hammer and it hurts, right? I'm upset and something painful happened to me. That's just a noxious stimuli, right? Where there's appropriate response to tissue damage. That's noxious stimuli. It's a stimulus that is damaging or threatens damage to normal tissues. Okay, let's go over another one. So I cut my thumb with a knife and now I can't feel the cigarette burning my skin. That's analgesia, right? I can't feel pain. Normally the cigarette burning my skin should be painful, but I can't feel it. And so I am anesthetic. I can't feel the pain, so that's analgesia. The definition is the absence of pain in response to stimuli which would normally be painful. Let's move on to some level 2 words. So when the bed sheets touch my foot, it hurts. This is a real complaint, by the way. So you'll see patients who come in with CRPS and they'll tell you these sorts of things. And they think they're crazy because it sounds so ridiculous, but it's a real disturbance that occurs during CRPS. And we call it allodynia, where there's pain due to a stimulus that doesn't normally provoke pain. So the bed sheets touching your foot should not be painful. So if they do, that's a difference between what it should feel like and what it actually feels like. So let's try out another one. So, doc, I feel like my fingertips are covered in sandpaper. So what would we call that? That's paresthesias, right? Where there's an abnormal sensation, whether it's spontaneous or evoked. This is commonly the pins and needles feeling, where it feels tingly. Patients will describe that it feels tingly. That's paresthesias. That's a tingly feeling or any abnormal sensation, whether it's spontaneous or evoked. So now let's add on that that's a painful burning, right? That there's a painful feeling. That's a dysesthesia. So if it's abnormal but not painful, paresthesias, the pins and needles. But if it's painful, then it's a dysesthesia. Dys means abnormal, and so this is an unpleasant abnormal sensation, whether spontaneous or evoked. That's a dysesthesia. Dr. Apel, the injection that you gave me felt like a hot poker that was burning my bone. This is the most painful thing in my life. So this is a stimulus that should be painful, but the pain that they felt was much more than would be expected. That's called hyperalgesia. So it's important to know these fancy doctor words when you're describing a patient that has a pain or a pain syndrome, to know exactly what it is that you're talking about. Are they describing allodynia or do they describe hyperalgesia? So it's important to understand the differences there. All right, so classification of CRPS. So CRPS can be broadly classified into two categories, type 1 and type 2. And these categories are, I like to think of type 1 as primary CRPS, where it's going to be due to an injury to the limb or some other event that happened to the limb. And type 2 as secondary, and secondary to a nerve injury, a peripheral nerve injury. So type 1 CRPS, on the slide here, you can see this is a case of type 1 CRPS. This was a massive trauma, a crush injury to this limb here. You can see how swollen it is. You can see all 4 metacarpals were broken. And this patient went on to develop CRPS. It can also be seen in cases with massive swelling, extensive trauma, or casts or bandages that are too tight. Type 2 CRPS can be due to a peripheral nerve injury, median nerve at the wrist, superficial radial nerve, but it can be any nerve really, and it's going to be a crush, stretch, laceration, or an identifiable peripheral nerve injury. So in addition to primary and secondary, or type 1 and type 2, another classification of CRPS can be sympathetically mediated versus sympathetic independent. So sympathetically mediated CRPS is classic, reflex sympathetic dystrophy, or RSD. The prognosis, it's not terrible. It needs a lot of treatment, but you can get it to improve about 80% of the time. That is if it doesn't go on to sympathetic independent, which is generally unresponsive to sympatholytics and overall carries a very poor prognosis. So the origins of pain in CRPS are complicated. So let's back up a little bit. So normal pain or nociceptive pain, as we discussed earlier, results from damage to tissues as a result of thermal, mechanical, chemical, or other irritants. Pathologic pain is where the nerves are the pathology, where the neuropathic pain is initiated or caused by a primary lesion or dysfunction of the central or peripheral nervous system. So it's thought that CRPS may actually be an exaggerated normal response to injury, because if you think about it, the normal response to injury is pain, swelling, increased blood flow. And we think that CRPS may be actually an abnormally severe or prolonged manifestation of what is the normal post-injury response. And so if you look at this figure here, you see that, let's just call everything the physiologic response on the the x-axis here. On the y-axis is time. Okay, so we're going to group everything together on the y-axis, which is pain, swelling, increased blood flow, all those sorts of things. So after an injury, you need that, right? And so they're going to go up after an injury, but as healing occurs and the tissues repair, that's going to come back down. So what is CRPS? CRPS is thought to be that it's maintaining that high level of abnormal physiology, and that it doesn't come back down with time. And so the origins of these CRPS are thought to be inappropriate regulation of the normal endogenous reparative physiology. So you might ask, well, why are there changes in blood flow with CRPS? And the answer is there are a lot of nerves on blood vessels. So here are some figures from this article that are showing us the axons that surround a blood vessel. So this is some great confocal microscopy here. And what we've got is we've got the smooth muscle arterioles, that's the A part, that are all colored, and you can see the striations of the smooth muscle arterioles, and then the green are axons. And you see all these axons that cover blood vessels. They're everywhere. They're all around it. They are running along the blood vessels, and they're crossing through it. And we know that this occurs because we know the normal pattern of the autonomics is to travel along the blood vessels. That's all this green that you see on the edges of the blood vessels here. Those are the autonomics that are traveling distally. But they also densely innervate the blood vessels themselves. You see there in figure J, you see all of that mesh network all over the arterioles. Those are the sympathetics that are affecting the smooth muscle fibers that control blood flow. And here's some classic studies done. I think these are 30 or 40 years old, that show that the peripheral nerves also carry autonomic fibers in addition to the blood vessels. And so here are some classic pictures that show after local anesthetic of a ulnar nerve here on the left. You can see the difference in temperature change with the white being hotter, how there's a dysregulation that occurs, and then same thing on the right when the median nerve is blocked. You see all of that area of anesthesia marked with the Sharpie marker, and then you can see the white, which is the temperature change associated with that. So the peripheral nerves carry autonomic fibers, and the blood vessels carry autonomic fibers. So here's a great example. This is a kid who had a median nerve injury from a supracondylar that I followed. And you can see, this is right when his median nerve was starting to come back. And you can see the wrinkling that occurs in the, we did a warm water test on him here, the wrinkling that occurs in the ring and small fingers. So that's the autonomic response traveling through the ulnar nerve. But you can see his median nerve is starting to get better because the thumb is better already. And the innervations come out to the thumb, and that's why the thumb is all wrinkled. But the index and long finger reinnervation hasn't occurred yet. And you can kind of even see that line of demarcation right about the level of the distal palmar crease there, where the sympathetics haven't grown back out into the finger. And so, so this is a way that you can see dynamically in your clinic sympathetic fibers as they affect your clinical tests, in this case a warm water test, and it will also get better with time. So here's a diagram of how that works, especially in CRPS. So start with the middle here on this figure, and you can see the AVAs, the arteriovenous anastomosis, and the nutritional capillaries are up at the top. And so in a normal hand, about 90% of the blood actually bypasses the nutritional capillaries and just turns around and goes right back where it came from. But about 10% does go to the nutritional capillaries. So on the left, this is going to be, type 1 CRPS, sympathetically mediated with increased total flow. And so what happens is there's dilation of the arterioles, and we get more shunting, more arteriovenous shunting. So in this case, you see we've got 95% of the total flow now is going through the AV shunt rather than 90%. So what happens though is there's actually less blood flow that goes to the nutritional capillaries. In this case, you've gone from 10 to 5. And so the result of that is relative ischemia and pain. And that's why you can have increased blood flow, yet it's still painful. On the right, we've got the flip side of the chronic burned out CRPS, where there's less overall flow, which is why that's a cold, stiff hand. But because there's less overall flow, there's also less nutritional capillary flow. But the common pathway for both is that there's cutaneous ischemia and pain. So the factors involved, I'm not going to get into all of these. This is a very complicated physiologic process, but it involves multiple different chemical mediators. The exact contributions of each, relative contributions of each is still not yet known. The S in RSD is sympathetic. We know that of all of those factors involved, the alpha adrenergic receptors are key because they do mediate local blood flow in sympathetically maintained CRPS. Phentolamine, which is an alpha agonist, is known to give some relief, and it can also be used as a diagnostic test to determine type 1 sympathetic mediated versus non-sympathetic mediated. We think that CRPS type 1 is probably a receptor mediated disease, just based on the response from phentolamine and some of the other neurophysiology that's known about it. Here's a figure that shows the circular mechanism that occurs. You can start here at the top, where you've got original injury initiates a pain impulse carried by the central nerves to the nervous system. The pain impulse in turn triggers activity in the sympathetic nervous system, which goes back to the site of injury. The sympathetic impulse triggers inflammatory response, causing spasm, increased blood flow, and pain. For the reasons that we talked about earlier, pain triggers another response, and it just makes that cycle, go over and over and over again, and that's the vicious pathologic cycle of CRPS or RSD. All right, that was exhausting. That is the basic physiology of it. Let's get into a little bit more clinical stuff. So, who gets CRPS? So this is a problem that affects women more than men. Women 4 to 1 are affected. The average age is about 50 years old. Upper extremities are more common than lower extremities, and there's an increased risk in smokers. And the exact reasons for these predilections are really unknown. In the upper extremity, the most common inciting event is just a garden variety distal radius fracture. It's important for us to know, we did talk about at the beginning of the talk, like, why do we need to know about CRPS? Well, the next two slides are partly why, because we can be the cause of it. The important iatrogenic causes include a tight cast after distal radius fracture. This is controversial about the cast versus a splint, long arm, short arm cast, those sorts of things. But there have been some basic science studies that have shown that tight bandages or tight casts can induce CRPS. Just remember that we can fix bones, and it's a lot easier to fix a malunion than it is to fix CRPS. And I would argue to you it's better to lose reduction and need open reduction, internal fixation, or takedown of a malunion than to develop CRPS. It's a lot more solvable problem. What's interesting is that there is less incidence of CRPS after operative treatment of distal radius fracture than there is non-operative treatment. It's about 6% for non-operatively treated distal radius fractures, and it's less than 1% for operatively treated. Other causes, you can damage the palmar cutaneous branch of the median nerve. You can do it during carpal tunnel release. You can do it during a distal radius fracture. Other important iatrogenic causes are damage to the SRN during a de Quervain's release. It's right there. And for those reasons, I don't use any self-retaining retractors like the Wheatlander you see pictured here. My concern is that they can fall out of the wound. They can kind of fall off. You've got them sitting there on top of the wrist, and they fall out. And as they fall out, they can snag the superficial radial nerve on the way out. I use all handheld retractors when doing a de Quervain's release. You can certainly damage the dorsal branch of the the dorsal-cutaneous branch of the ulnar nerve during any approach to the distal ulna. That'll lead to symptoms sort of right here on the back of the hand on that dorsal ulnar aspect of the hand. Injury to the LABC during a distal bicep tendon repair. This is an interesting one. It's thought this may actually be a traction injury from bringing down the biceps tendon. We believe here that this can be minimized by doing a neurolysis of the LABC as you release it off the biceps before bringing it down. Again, we don't have the evidence that supports that, but certainly given how ubiquitous LABC neuritis is following distal bicep tendon repair, it just seems unlikely that it's from retraction injury, and it seems it's much more likely from traction, especially because it's been stuck down to that biceps, for however long that the tear, has been retracted up there, and as you bring it down, because it's stuck to the biceps muscle belly, as you're pulling it down, it causes a traction injury of the LABC. So moving on to treatment of CRPS. It's not as easy as you think. This is another Far Side comic. Unknown to most historians, William Tell had an older and less unfortunate son named Warren. Sometimes I feel like this with treating CRPS, that it seems so easy, yet there's so many ways to fail. I want to start off with talking about surgery that can cure CRPS, because for us as surgeons, this is probably one of the most important things we can do. And it starts with examining for an underlying cause of the CRPS. If there's a nerve injury, we can correct the lesion. We can excise and graft it. We can do targeted muscle reinnervation or RPNI. And this can reset that pathway of the brain. It lets the nerve reinnervate normal tissue or reinnervate normally again, and then stop sending neuropathic signals. Other ways that are thought to do this with peripheral nerve blocks and blocks of the sympathetic nervous system, the stellate ganglion blocks, are thought to temporarily reset that cycle, to block that cycle. But certainly if we can find ways of permanently altering that cycle, the treatment is likely to be durable. Non-surgical treatment starts with a multidisciplinary team approach. Typically, this is going to involve a pain management specialist, PM&R, and therapy, as well as yourself if you're the treating specialist. We use a lot of topical medications. Certainly I do. Ketamine and gabapentin creams. Oral medications, depending on your level of comfortability. There's some calcium channel blockers and SSRIs that are used. And therapy, physical therapy, as well as psychological therapy for the long-term management. These patients have a lot of impairment in their lives from this problem, and it needs management from a psychological standpoint to cope with the disease, not because that's the origin of the disease, but to cope with the disease. And then physical therapy to manage a lot of the physical manifestations. Long-term management may or may not be the hand surgeon. I don't manage this in my practice in the long term. I don't really have the resources for that. Some hand surgeons do. That's a personal preference about what you want to do. Certainly, though, I think you should be facile in initiating first-line treatment. Amitriptyline at low doses, 25 milligrams, can be a good treatment. It is a sympatholytic. It does cause drowsiness, so we have patients take it in the evening. Gabapentin is a membrane stabilizer. You can start off at a dose of 300 milligrams 3 times a day. Amlodipine is a calcium channel blocker. Does also have a significant side effect profile, including orthostatic hypotension, and can cause headaches as well. But 5 milligrams is a reasonable starting dose. Steroids, it's uncertain, if the steroids, what effect they have in the long-term management of it. Certainly a burst with a taper when you first recognize CRPS can help you get out in front of it. In the long-term management, though, I don't think there's a role for steroids. Here's the topical medications that I use. I use the ketamine and gabapentin creams. There's a compounding pharmacy here locally that we use. You can probably contact a compounding pharmacy, in your area to get these made up. There's a lack of empirical evidence for the treatment of CRPS, and so a lot of these things that I'm talking about here come from either my experience or from some very, very basic science data. But these are patients that have problems that don't have evidence-based solutions. So we use whatever we have access to. Certainly, I think there's near universal agreement that therapy is an important part of the management of CRPS. Therapy can focus on edema control, range of motion, as well as desensitization exercises. That includes things like mirror therapy and sensory re-education. There is a reasonable prognosis of CRPS. It's not horrible. I don't think I would want it, but it's not horrible. About 70% can get a resolution or improvement in a year. I think they're always still a little stiff. That's certainly been my clinical experience. And while you can oftentimes get the pain under control, it's pretty uncommon that you end up back with full range of motion. And I would just advise patients that although we may be able to improve you with treatment, you're likely to be left with some sequelae. So advanced treatment is really beyond the scope of my practice and really beyond the scope of this talk is phentolamine, clonidine, which is an alpha-2 agonist, stellate ganglion blocks. Those are often done by our pain management colleagues. Ketamine comas are often used. I can tell you that there's no data that demonstrate their efficacy beyond 90 days. There's no durable long-term data on ketamine comas. Botox and bisphosphonates have also been used for the management of CRPS that have been described as well. That's it. I hope this gives you a good preview of CRPS and can get you started with some of the tools in order to treat it. Certainly, if you have any questions, leave them in the comments or you're welcome to email me. Appreciate everybody's attention.